you want to do this. Like, you really want to try this. You're comfortable, like, explain everything, and you feel good about it. Yeah, why not? You explained everything well. I'm here for treatment, and thank you for actually going to do this. So, yeah, let's go for it. Okay, let's go then. Hello, this is Omar again. This is the episode of Talk Therapy Pod with myself, Omar Green. See, it's been that long that I don't even remember the whole intro. And thank you to, I forgot the YouTube name, but there's a YouTube channel. As I've been doing these videos more and more, I want to get into sort of editing and doing a lot of cool things. And so that was your cool little intro video about self-determination that I did actually a week ago, prior to doing this here, as I've been a little busy in terms of doing things for the my practice, doing things for the podcast, even behind the scenes. It's been interesting to do this, but I still like to come to this little passion project. It's kind of cool to do this. It's kind of cool that you can do this in a modern world. So it's a really cool thing. So this is gonna be the first part. And everybody also like, subscribe, comment, smash like buttons, do all those things. But for this episode, I want to talk about literally not even ethics completely, just one part of determination. So a couple things that I've experienced in the past, a couple things I've experienced lately, just on my travels, have really brought this to the front of my mind, because it's such a simple concept in, like, it's how you would state it or how I would sort of explain it to someone. But, you know, as simple as it is, it still sometimes feel like it's just not fully embraced. And it's weird because without the simple concept of self-termination, it's, you know, an entire treatment of someone's care can kind of fall down, because everything sort of starts with the patient being on the same page as you are. And then the first part is getting them to agree on some level to where you are. Doesn't mean you agree about literally everything in the course of treatment. It just means that at least there's some level of agreement about what's happening during treatment, the issues to be confronted on during treatment, and the interventions that will be used during treatment. And that's essentially almost self-termination, right? To be, I'm not going to go into the exact definition, but you can and should look up the definition in the NSA Code of Ethics. It's literally one of the first tenets. I think it's either that or informed consent, which goes hand in hand. But essentially, it just says that everything that you're going to do with a patient as a provider, mental health provider, you have informed them into, and that's why they kind of go hand in hand, informed consent, and they have agreed to. And honestly, that, as much simple as that sounds, you know, as I did research into self-termination, and it actually is a very long history into this one tenet by itself, that kind of shows that there's a lot of different ways of thinking when it comes to a patient's ability to choose for themselves. But as simple as that sounds, you know, I've seen times where either there's been a difference of opinion how things are, and those things can just either come from failure to live up to ethics, or maybe a different understanding of ethics. And those difference of opinions or failures can really lead to someone's care being sort of jeopardized. But in this first section, I think I'll go over the few times you can, decline someone's self-termination. You can overrule clients' own ability to make choices for themselves, because you are responsible for the patient's safety and for the community safety at large for which you serve. And that enables you, empowers you, especially if you are certain credentialed like a LCSW, like I am, to be able to override someone's self-termination. And so we'll go into that there, and then maybe third section, we can just kind of go into what I've read about the history of self-termination and how it sort of evolved throughout the time in terms of mental health and psychology. But let's go over the exceptions. And a little fun fact, I actually already did this video, but it somehow got lost in the ether, so this is a redo. One of the first ones where you could actually overrule someone's self-termination is if they say they're going to harm themselves, right? Like if they make any statements that sort of imply self-injurious behavior or intent to harm or thinking about harm to themselves, and especially if you do a risk assessment, a thorough risk assessment of the ability to harm yourself, and you conclude from whatever the risk assessment is that this person has intent to harm themselves, has methods to harm themselves, and most likely will harm themselves, then you have the ability to override someone. That's the whole point of a document like the PEC, or the Physician Emergency Certificate, is that you can override the will of someone else because you as a provider honestly think that they may be a harm to themselves. Now, because it's so powerful and daring and it is someone's life, I always think of these things of like, I wouldn't want someone to do that to me, just to be so flip about the things that are going to affect me one way or another. So because of that, I take extreme caution of doing that, but I have done that. And I have ruled against people as well. A few times where I just thought they were dangerous to themselves. And I thought that if they leave this office and I don't do anything, they may harm themselves. Now, that is almost a whole conversation in itself, a whole video in itself, that I don't know if I already did, but if I haven't, we can do that, about risk assessment. And it can go from them not, doing anything at all in terms of needing extra services, to them needing more services, to them being to volunteer themselves in hospital, to leading to them actually being hospitalized against their will, depending on how things go. But that's one situation, without going too deep into that subject. Another situation could be if they want to harm somebody else, right? And I've had that happen, where due to disputes between maybe the patient I'm seeing and someone in the community, they really talk about harming someone else. It's essentially the same thing as risk assessment. It just, instead of the harm being done to themselves, you would assess the ability to harm someone else. And if you really feel that way, then you can proceed and hospitalize that patient. And to kind of go deeper into this, because I do think I want to mention this when it's relevant, is that we try our best to be compliant with all the ethics, and we try to be culturally competent in terms of the risk that we run. when we do these risk assessments, and in terms of being forceful enough to know when there's an issue to act on it, but still giving the patient every opportunity to be compliant and work with us. And any barrier that could be in that way, we try to remove. And one thing that's come lately, especially with the rise of awareness of the centuries-long ongoing oppression of Black people, is that a lot of Black patients talk about not wanting police. So even though it's not directly this, I have had situations where I've had to mediate with police officers that were trained to be a little more sensitive to people that doesn't want police present because they feel triggered, and understandably so, because there have been several instances where people want a mental health wellness call done, and the police show up and they are excessive, and they show no understanding for someone that is presenting or experiencing aggravated mental health symptoms, and people are hurt, people are killed. So literally, it's like, I completely understand as a patient, why would you call someone to come kill you? So what I've done in that situation is ask my town, and I've actually got a couple towns on board with this, is to have them send mobile crisis in, which would not have any police and would need police unless they got violent or threat violence to the providers themselves, and that has been somewhat of a solution. And in other places, you're hearing mental health professionals go out with law enforcement officers. Actually, in my hometown of Bloomfield, that's happening as well. But to continue on, so we talked about harm to self, harm to others. Now there's a third category, and it's vague in the way I term it, but I kind of put a few things in this category. And the category is like grave risk to the community. And grave risk to the community essentially is just saying, if I let you out of this office, maybe not like right now or tonight, but very soon, the way you act and present yourself, either you're gonna get yourself hurt or you're gonna hurt somebody else, even if unintentionally, just because of how aggravated the mental health symptoms are. And so I would put people who are in deep psychosis in that. I would put people maybe that are having intense manic symptoms in that category. I would put any people that are really intoxicated in that category. I have forcefully, against someone's will, hospitalized people that have come in intoxicated on alcohol, intoxicated on PCP, and other drugs. They can't walk straight. They fall down all over themselves. You're seeing someone that's so unaware and able to sort of handle themselves that they're a danger to themselves and the people at large. And I would say those are three main categories. Although the first time I did this video, I learned there are a few others. So I'm going to go through one or two more, and then we'll end a second. One is it's tear us off if, and it's our duty to warn and protect if we feel that someone is a future victim of intimate partner violence. We do have a duty to call the police, warn the victim. The victim might be our patient, or maybe somebody to the patient. Now, yet again, I haven't thought about this until literally right now, but this may run into the same situation I talked about with mobile crisis. So that's something there, but for release right now, I'll stick to the academics or the way I was taught to call the police and warn the victim or the potential victim. This usually goes back like to the day before of the account, but it's only that liberal to go to that day before. And the only other time maybe would be in abuse cases. So abuse of like protected populations, which are basically elderly people and children and also disabled people. There's been times where I've had to do things based on possible elder abuse or child abuse. And off the top of my head, and I'm like thinking about this now, I didn't write down, I don't like to like be too prepared for these videos. That's it. Those are all the situations. I guess one more situation is more of an environment and less a situation. It's prison. In prison, you lose certain rights, and so when all staff has somewhat of a authoritarian relationship with the inmates that are there, and so in that way too, they don't have self-termination all the way, but that's more specific to that environment. But other than those things I just mentioned, we respect people's self-termination. If they don't want to do something, we let them just not do it. And that doesn't mean there aren't consequences. There's technically another category I could have put in. I could have put court-mandated people in there. They technically don't have self-termination because they're mandated by court, but even technically they do. They just would face a consequence after. So I'll go more into self-termination after this. I'm crafting making this video, but I'll see you guys on the other side of the card. For on the other side of the card, for the final portion of this podcast. This has taken a long time. I know it's been a really complicated time for me, and so apologize. But honestly, I do think it's a little blessing in disguise, because as I continue to practice with patients, I continue to sort of have different experiences that highlight the things I talk about in these podcasts. And so we're talking about self-termination, and I talk about the first section about sort of the general idea of it, the place where you can violate it. The second part, the old way of thinking about it that I would say still persists till this day, that it's the professional that knows best, and that the patient doesn't really have a decision or has a stake to claim in any of the decision making. And then here's the third one, where the patient does. So as we talked about before with Freud and everything that he did in his group, as they were starting to really make the formal structure of mental health as a treatment, as a discipline, some of his offshoots would actually go against him to say that patients need to be able to make their own decisions. And that's where the camp where a lot of people are in today. That's the camp where I'm in today. I do think that there is something to having a professional who is studied in symptomology and studied in the cause and effect of what's going on. But for a lot of reasons, and something maybe I've already kind of said in the second portion, being able to determine what you want is so important. One, it may not be the right treatment. In terms of one of the things I mentioned, I think in the previous section, I've had a ton of patients who come to my office, and and I usually just ask them, hey, what are you here for in terms of mental health? And they'll say, I don't know. And then I'll just say, I don't know. And that has been something that has been disturbing, because if you don't know the issue, how can you know if there's something to be treated or not? There can be a lot of reasons why people are uncomfortable A lot of procedures and mental health services, some could make them uncomfortable, whether it's being phrasing, whether it being some of the things we do to ascertain data about things. I think like tax screens and for the use for substance use. There's a lot of things that can make you feel uncomfortable. And one of the biggest things you want to have as a practitioner is a sense of comfort. Way back when I took my favorite psych class at UConn, Psych 202WQ, I remember looking at all the different levels of validity and reliability. And validity is essentially just saying the things that we're finding are because they actually are what we say they are. And one of the biggest things is to make someone feel comfortable, essentially. Comfortable enough that they will elicit an honest response. That's why, you don't talk in sort of jargon. That's why you try to build a rapport with clients, because you want them to be as honest. And that's why, ironically, I'm doing this video right now. But there's so much stuff in telehealth. And one of the benefits of telehealth is that people are kind of comfortable. They're in their bedrooms, they're in their living rooms, they're in their backyards. When you come to an office, you're conditioned. You see all these professionals in suits and ties. You see this really overwhelming structure. It's not like you're home. And so therefore, you're not gonna maybe give me the best response, the most forthcoming and detailed responses, because you feel like everything has to match the environment that you're in. Versus my time when I was a program clinician for another organization, I got to see their honest behavior. I first experienced the most presentable answers that you want to bring to a professional to put themselves in the most best light, and then I saw what they really act like, because after a while, because they literally lived in a group home, that's where I worked at that point in time, they're gonna be who they really want to be, or who they really are. So therefore, self-termination goes a lot into getting the best responses from people and the most honest responses from people, and respects that people have a sense of independence to choose what's right for them. Now, even that line can be taken to some extreme, so even that notion has some limits to it. But in general, you should be able the idea to choose the sense of treatment that's right for you and that you're comfortable with. Because in a sense, as I said in the last session, or in the last segment, you're not going to be motivated to do certain treatment, and that's going to cause something we call transference, and that might even cause countertransference, where you have a sort of a back and forth between the provider and the patient, and there should never be any personal issues with that. Ironically, I've had patients in the past where it's been a struggle to continue to maintain it, because they're constantly making sort of antagonistic statements toward you. It's hard, but at the same time, every step of the way, I made sure that if they wanted to do something, that as long as it's within reason of their self-termination, they got it done. And then also, I explained everything. And as I mentioned, informed consent, I explained the different treatments to the best of my abilities, modalities, interventions, why I think they should be referred to one professional versus the next. I did all that stuff to sort of boost up self-termination, because when you have collaboration and you have someone that's on board, you have someone that's going to be more forthcoming, you have someone that's going to be more honest, you have someone that's going to be more motivated to participate in whatever treatment that you're assigning to them. and you have someone that's going to tell you honestly about themselves. As professionals, we may know academically what is going on with the patient based on symptoms and modalities and interventions that we've been taught, but no one knows your body better than yourself. So they may not know what to call that intervention or condition. They know how bad it hurts. They know how much it hurts. They know when it's working, a treatment, when it's not working. They can tell you more than anyone else. And so whenever I see people just trying to overrule or push something on someone, it really irks me. And I think that's what inspired this podcast, this episode anyway. And so yeah, I think that sort of covers sort of the benefits of it in terms of making sure your treatment responses are valid and making sure that you have patients that are highly motivated and want to participate in treatment and want to actually be a part of the team and then actually want to continue going forth. Ironically, even to the people who feel like they may want to do something and best instant, because there are those times where the patient has done things that are not in their best interest health-wise, right? Like from my professional opinion, a doctor's professional opinion, and so forth. But even then, even at those times, you are more likely to get the patient to agree to something they maybe initially disagree about through psychoeducation, through exploring why the reasons why they may not feel comfortable with a certain treatment. But all of that starts with respecting the fact that they're saying no in the first place. And that's happened several times where I've had patients that have said no initially, and maybe it's not, the next session is maybe like some months down the line. And we review the reasons why they were initially against a certain intervention, the benefits, the cost. You should always do that. The meaning of everything to them as a person, and they eventually do that intervention that I said to do initially, and they at times see the benefit, because most times I think I'm sort of accurate on what people should do and shouldn't do to help out. And so even in that sense, you should also always respect what someone's comfortable with and what they're not comfortable with, because there's a lot of power that comes with these positions, and it's not, I don't take it, I'm not flipped about it at all. I take it very seriously, and these are people's lives, and our decisions affect them. So anyway, that's it for this episode. I'm sorry it took super duper long. I try to keep the different parts of this little passion project, private practice, business, whatever you want to call it, sort of separate. I am gonna start putting them together, and so when I do that, you're gonna hear a lot more about the other parts of this practice, whether it's the practice itself, the collaborations I'm trying to do, the collaborations I'm kind of already doing, and I don't want to talk about on camera and on internet yet. And that's going to explain more to why there's like so much like helter-skelter in terms of like not a consistent schedule. But I'm going to try to do better with this. But until next time, enjoy everything, stay safe out there, and breathe easy. Peace. And we're back on the other side of the card. This is taking a while, but honestly, I want to continue to try this. This is a labor of love right now, and I want to continue to push for this video podcast to come, even if it's an irregular schedule, which it comes out right now. I want to continue to get used to this just because at some point I like it and I aspire to do this more and more. And it helps me. It helps me in a lot of ways. So I don't know if anyone's commenting yet, however. But yeah, I want to continue this. So last segment, we talked about the few ways in which someone can violate someone's self-termination, their ethical right to basically choose what they want to do for treatment. And I talked about those things being basically self-harm, harm to others, and then a few other things that sort of give us the power, and not really even the power, hold on, I grasped up, the responsibility to help patients because we think they might be a danger to themselves. So those are a few times. Now I want to almost ironically continue on the point of not respecting someone's self-termination based on my studies. So a few weeks ago I read an article. I was thinking about reading it and getting ready from here, but I like these more casual talks where I just sort of give you my summary of it, because I know there's probably more articles about this. I do research to prepare for this podcast, but like there's so much information out there that if you have a different opinion or perspective or even something that adds on to mine, definitely add it in the comment and we can chat about it below. So I read a couple articles about how psychology started and the basically the practice of it, and it all starts with sort of Freud and his school and all his like early students that sort of splinter off and do their own practice that is sort of inspired by Freud, but still not Freud itself. And so back, when he was starting off, I think it was like the 20s, 30s, somewhere in there, it was very much what I've heard today is sort of a medical model where they were considered to be the professional. Whatever they saw, and whatever the recommendation was, you as a patient just went with it because they were the professional, you were the patient, and that was it. And they thought that they should know best about when things should be something you should choose, and they thought about best when it was something you shouldn't choose. And maybe they were victims of their time. They were in a space where the profession wasn't as developed and refined as it is today. We didn't have as much mandates because a lot of the things I talked about in the previous section happened only because of certain incidents. Like the Tarasov thing happened mainly because of an incident happened with a woman when a therapist could have intervened to warn police about her being possibly assaulted or hurt by some person that she was going after her. So a lot of those things just didn't happen, and they didn't have those thoughts, provisions in their head as they were sort of going about their practice. But that model does still hold a little bit of weight today, even if it's not practiced fully. But just stay with my profession. In mental health practice, I have seen several people try to talk people into diagnoses they may not have, talk people into symptomology they may not have, talk people into doing certain practices, all with a thought of they're a professional, they've eyeballed it, they've assessed it, and that's it. And it's been, and honestly, those times it's pretty challenging because it was one of those things where maybe I disagree with it, and it doesn't leave room for any suggested learning and continued learning about an assessment. The way I sort of think of an assessment is it's almost like a working document, right? It's a thing that almost never ends. And I remember it reminds me of the class I went to to learn how to diagnose people. And the professor was talking about this one patient, and he had only two disorders. He had major depressive disorder, and he had dysthymia. And he talked about how the two disorders are similar but different, and how in different parts of his life, different periods of his life, the order of the two disorders would just change. It would be one time it would be dysthymia, one time it would be major depressive disorder. It would just change based on the things going on in his life and the symptoms that are more prevalent and more present. And so it's a working document, and I think that even when I think I have an assessment down, I'm willing to hear additional information. I'm willing to adjust different things as I hear. Now, let me talk about that, how even that, maybe not that, but that can be taken the wrong way. I've seen people in my profession almost become like private eyes and have this very like judgmental sort of way of thinking of clients and sort of thinking the worst of them. And I think there's a lot of danger in that, because where does that come from? Does it come from prejudice? Does it come from sexism, racism, classism? I've been in circles where people have talked lowly about people based on the area they are, suggesting that a certain attire or the way they carry themselves automatically, define them as one thing or next. And so, until I sort of play it neutral, can I make estimates about certain clients? Yes. And I think I can even make state estimates of certain clients just based on the amount of times I've seen people that come from a certain subpopulation. But even if that's a best guess, I still don't think it. I can't completely confirm anything is going on with that client until it happens. Like I can have in the back of my mind that person is maybe lying or maybe not being as forthcoming, but I don't have anything to substantiate that. And that's something, a lot of people learn if they take classes like 202 WQ psych class. It's a class I took in UConn that pushed us to learn how to ethically conduct an experiment, a psychological experiment on people. And it was about validity and ethics, but also about business statistics. And it showed that, even things we know mathematically can't be proven to 100%. And that it is on us, the burden is on us to consistently look for things to substantiate something. And so just guessing that a client is not being truthful or guessing that a client is holding back information and just thinking them as an inferior source of information, I just don't follow, and I just think it's wrong. It's unethical. I say to clients I may have the information and the data of how to do things from a psychological standpoint, how to assess you and intervene, but it's your life. You know it better than me. And so I have seen that. I've seen people try to force people into doing certain things. I've seen, one thing sort of irks me, I've seen people look up criminal records, which it's weird. I don't know how to make sense, especially in this day and age, right? This thing, whenever it comes out, it's coming out in 2021. The protests, that sort of reached a climax and reached its peak in terms of mass protests happened a year ago in 2020. And so right now it's pretty much general knowledge that there's some issue with our criminal justice system and that they're not as forthcoming, sometimes they're not truthful. So even that, I don't completely trust forthcoming. It gives me an idea, maybe it gives me a thing to check and look into something, but they can be wrong because they've been known to falsify and exaggerate charges. And so even that I don't take at face value. So yeah, I think I've seen people have that that thought, that old school thought of I'm a professional, you are the patient, you come to me, I'm going to tell you what it is, end of story. And I completely disagree with that. I think the article goes into how people, the first wave of Freud's students, as they sort of built their own practices, one or two started to think differently and started to sort of explore what it is for a patient to think for themselves and having the ability to make decisions for themselves. And that's more what I meant, because like I said, there's a lot of thought that, and one of the things that is, not to kind of completely spoil the last segment, is sort of the idea I talked about briefly of informed consent. And the fact that, for people who do take this medical model and don't give people, or don't impress upon people to use that ethical right for self-determination, they don't even know what's going on. Like, I've had so many patients that have come into my office and they don't know why they're there. They don't know. They come in, they sit down in front of me. I say, why are you here? And they say, my doctor told me to come here. That's not good. You know what I mean? Like, even if I don't know exactly what's going on, I can tell you some approximation of symptomology or feeling or pain, something that's led me to come here. And so it's something to continue to work on. It's something that I think, as all mental health providers, we continually should encourage our patients' ability to advocate for themselves and to have self-determination through every aspect of treatment. That means even, hey, I'm gonna come to this place or not, I'm gonna go with that intervention or not, I'm gonna go to that doctor, go to this therapist. You as the patient have the right to decide every aspect of it. And on the other side of this card, whenever we film the last segment, I'll talk more about all the things that empower you and empower other patients to do that. See you on the other side of the card.